He gave us some names
Mm-hmm.
and he also modified the program a little bit. Good evening, everyone. So, welcome to DOS PEP with another chapter. And today we have an excellent speaker for the topic. And thank you all for being a part of this program. It's been already almost 5 months, and still you all are there with us. Thank you so much for that. And I request the coordinator for today, Dr. Pranita, please introduce our speaker, and then we'll move ahead with the talk.
Good evening, everyone. Thank you, sir. So, as sir has already welcomed all of you, we are today on the 38th lecture of DOS PEP and the 16th lecture for the Retina module. And we have an eminent speaker with us, Dr. Mallika Goyal, ma'am, who will be talking about an important topic, hypertensive retinopathy and retinopathy with blood dyscariasis. Hypertensive retinopathy is an important topic because that can come as long case, short case in your vivas as well as your long question. And even in your OPDs, it is important for you to identify these patients and grade them well, about which ma'am is going to discuss in detail. We are thankful to Dr. Lalit Verma, sir, who needs no introduction. He has helped us in selecting the topics and the speakers for the Retina module so that it is helpful for all the students. And we are also thankful to Dr. Anupam Sachdev, sir, who is the co-director in Institute of Child and Health and has helped us in getting the ANBI collaboration, which is an association of all the NBE hospitals with it running the DNB courses in their particular hospitals. So the speaker for day is Dr. Mallika Goyal, ma'am. She's a senior vitreoretina consultant and UVA specialist at Apollo Hospital in Hyderabad. She's done a post-graduation and senior residency in retina and uveitis from the prestigious RP Center for Ophthalmic Sciences, AIIMS, New Delhi. She has won various awards and honors, and some of the recent awards include the most trusted ophthalmologist in Hyderabad, and the best surgical video at AIOS, senior honor award and honor award from the American Society of Retina Specialists, and top contributors for the Retina Image Bank, and the list goes on and on. She has the present leadership positions include President of the Hyderabad Ophthalmological Society and Senior Editor of the Retina Image Bank, which is a part of the ASRS. Also, she has been a member of the Scientific Committee of the AIOS and Chairman of the Scientific Committee of the Andhra Pradesh State Chapter, and editor publications of the Andhra Pradesh State Ophthalmological Society, and Vice President of the Hyderabad Ophthalmological Society. So, ma'am, with that note, we welcome you for your class on hypertensive retinopathy and retinopathy with blood dyscariasis, and we look forward to listening from you, ma'am.
Thank you very much, Dr. Pranita, for that introduction. I'd like to thank the entire DOS, Dr. Lalit Verma, Dr. Praful Maharana, Dr. Pranita Sahai, and everyone for this opportunity. So I think without further ado, we start with the talk on hypertensive retinopathy and chorioretinopathy. So WHO defines hypertension as systolic pressure of over 140 and or diastolic pressure of over 90. Poorly managed hypertension affects several systems, which is known as target organ damage. The most commonly affected target organs are cardiovascular and cerebrovascular, renal, and retina. Ocular damage includes retinopathy, optic neuropathy, and choroidopathy. Now, what is the significance of hypertensive retinopathy? Retinal vessels are the only blood vessels which are amenable to examination by a physician. And these reflect the vascular changes happening in all other systems. So, retinopathy is a predictor of morbidity and mortality, coronary events, stroke, renal dysfunction. And it is associated with an increased stroke risk even after controlling BP and other risk factors. Now, it is seen in a large proportion of hypertensive patients, but it is missed because it is asymptomatic. The incidence of hypertensive retinopathy is directly proportional to the severity and the duration of hypertension. Surprisingly, it is not seen so much in elderly people as it is seen in younger people, probably because of the sclerosed vessels in the older age, which do not allow the changes to be seen. The median age of patients with the grade 3, grade 4 hypertensive retinopathy is 16 years younger in hypertensive patients than those without. What are the factors which predict presence of hypertensive retinopathy? The most important is the presence of renal disease. Also more common in women. certain genetic factors such as deletion of allele of angiotensin converting enzyme, smoking. Why do we see hypertensive retinopathy is because of the specifics of the retinal blood vessels, which are distinct in that they do not have sympathetic nerve supply, they have autoregulation, and the presence of blood retinal barrier. It is these last two things which features which cause the specific characteristics of retinopathy. When blood pressure increases, the autoregulation comes into play. There is a vasoconstriction, and we start seeing retinal arteriolar narrowing so that the arteriovenous ratio starts reducing from the normal 2:3 to 1:3. Though this is not seen so much in the older patients because of the sclerosis. Persistent increase in blood pressure, however, causes permanent changes in the vessel wall with intimal thickening, media layer hyperplasia, and overall hyaline degeneration of the arteriolar wall. This leads to opacification of the arteriolar wall, causing increased light reflex, copper wiring, silver wiring. And because this is now a thickened arteriole, it presses the vein where it passes over it in a common adventitial sheath, leading to AV nicking, AV crossing changes. So these are the sclerotic changes in chronic hypertension. As the BP increases further, the autoregulatory mechanisms are bypassed and there is a disruption of the blood retinal barrier as the vessel wall gets damaged. This leads to leakage of blood and plasma in the form of retinal hemorrhages and hard exudates, which are proteinaceous lipid material. Areas of ischemia are seen as cotton wool spots or microinfarcts. So we had the vasoconstrictive phase, then we had the sclerotic phase in chronic hypertension, and finally we have the exudative phase. And lastly, we have the malignant hypertension. When it is very severe, ischemia of the optic nerve head leads to disc edema. Also, there is believed to be increased intracranial pressure, both contributing to disc edema known as papilledema. So it is classified, hypertensive retinopathy is classified as grade 1, which is mild generalized retinal arteriolar attenuation. Grade 2 is focal narrowing with AV nipping. Grade 3 is presence of retinal hemorrhages, hard exudates, and cotton wool spots. And grade 4 is the presence of disc edema. Now, this is acute hypertensive retinopathy. But when it becomes chronic and sclerotic, then it is called classification of arteriosclerosis, which is stage 1, broadening of the arteriolar light reflex. 2 is AV crossing changes. 3 is copper wiring of the arterioles because of the increased light reflex. And stage 4 is even more severe changes, which is silver wiring. So these are just some examples. Normal fundus showing a 2:3 ratio of arteriole to vein, as you see here. But in an grade 1 hypertensive retinopathy, the AV ratio has become 1:2 or even less. Here again, the grade 2 hypertensive retinopathy, we are seeing AV nicking and the AV ratio is less than 1:2. When it goes into chronic hypertension, near the star is the copper wiring of the arteriole, increased light reflex, along with AV changes, AV nicking. So this is grade 2 to 3 arteriosclerotic changes. Why are we saying 3? Because there is copper wiring. 2, because there is AV nicking. So 2 to 3. Now we are coming again into the acute hypertensive changes, grade 3, where there is cotton wool spots, hard exudates as a macular star, and serous detachment. Again, we see the similar changes, macular star, retinal edema with cotton wool spots and macular star. But these regress very rapidly when the blood pressure is controlled. As you see, within 4 months, all changes have resolved. Again, within 3 months, 6 months, all changes have resolved. Macular star, serous detachment. Similarly here, cotton wool spots have gone, retinal edema has gone within months. And this is grade 4 with disc edema, bilateral disc edema. Choroidopathy is seen in younger patients, again, just like retinopathy. The choroidal arterioles undergo constriction and fibrinoid necrosis, which leads to non-perfusion of choriocapillaries and ischemia of the RPE, which then leads to serous, the RPE does the pumping action, and that when that is damaged, there are serous detachments and hemorrhagic detachments of the retina. Localized ischemia of the RPE leads to Elschnick spots and Segrest streaks, which is the streaks are at the margins of the choroidal lobules. So these are Elschnick spots in a patients with hypertensive retinopathy, pigmentary changes, Segrest streaks, and when there is an extensive choroidal dysfunction, that leads to RPE detachments and exudative retinal detachments, which can even be hemorrhagic, not always serous, as seen in malignant hypertension, preeclampsia, eclampsia, HELP syndrome, all of which are medical emergencies. So in eclampsia especially, vision loss occurs from exudative RD and extensive RPE necrosis or degeneration if the blood pressure is not managed in an emergent manner. Most cases, however, recover uneventfully because they are managed during the episode. Now, this is a patient with bilateral exudative retinal detachment in eclampsia, which resolves with management. Now, the important thing in eclampsia is we may not see other changes. We may not see hemorrhages, cotton wool spots. We may see just exudative retinal detachments. That can happen. Diagnosis most importantly by wide field digital color fundus photography, and nowadays the application of computer-based techniques to measure early changes and deep learning to allow risk stratification for stroke and heart disease. OCT is of course very important. We just saw detachments, edema, but also thinning of the inner retina occurs in chronic hypertension and attenuation of the ellipsoid zone in areas of Elschnick spots. Swept source OCT has a greater penetration, so shows us the choroidal thickness, which increases in the acute phase of hypertensive choroidopathy. The choriocapillaries, however, reduce in thickness with moth-eaten appearance due to non-perfusion. And finally, choriocapillaries may show reperfusion if antihypertensive treatment is started in good time. Fluorescein angiography, not very important, but shows patchy and delayed choroidal filling, severely delayed retinal arterial filling with areas of non-perfusion, disc leakage, and ICG shows hypocynescence of ischemic areas of the choroid. So this is a fluorescence showing patchy choroidal filling, non-perfusion of the retina, and disc leakage. Apart from causing retinopathy, more importantly and more commonly actually, hypertensive retinopathy is a risk factor for retinal artery occlusion, retinal vein occlusion, which is what we see mostly actually, more than retinopathy. Macroaneurysm of the retinal arteriole. It causes rapid progression of diabetic retinopathy if it is not controlled. Anterior ischemic optic neuropathy, arteriolar emboli, age-related macular degeneration, glaucoma is worsened by uncontrolled hypertension, and the risk for suprachoroidal hemorrhage during ocular surgery. This is BRVO caused by a sclerotic vessel passing over a vein. Now, hypertensive retinopathy in itself is usually asymptomatic, and all changes can be reversed when hypertension is treated. Vision is affected only when macula is involved by edema, hard exudates, or serous detachment. It rarely causes long-term vision loss except when there is optic atrophy from prolonged disc edema or hemorrhagic exudative retinal detachment, extensive RP necrosis, and retinal pigmentary changes after exudative retinal detachment. So this was hypertensive retinopathy. Dr. Pranita, should I stop or proceed? Dr. Pranita?
You may proceed, ma'am. Good evening, ma'am.
Okay. So this is the second part of the talk. Should I continue or there should be some questions on hypertensive retinopathy?
Ma'am, questions will be asked at the last of both the topics.
Right. So we'll move to the second part of the talk, which is retinopathy with blood dyscrasias. Now, retinal abnormalities can be the first manifestation of blood dyscrasias, but the findings are non-specific. They do not indicate that there is a blood dyscrasia. It presents as retinal hemorrhages, cotton wool spots, rod spots, hard exudates, non-perfusion, leading to neovascularization and infiltration in the case of leukemia. The level of anemia, thrombocytopenia, and hyperviscosity correlate to the presence of retinopathy. Surprisingly, WBC count does not correlate to the presence of retinopathy. So it is only anemia and thrombocytopenia plus hyperviscosity if it is there, which contribute to the presence of retinopathy in blood dyscrasias. The first blood dyscrasia being anemia. Just anemia does not usually cause any retinopathy. It's a combination of anemia and thrombocytopenia which can lead to retinopathy. Vision remains normal, but anemia can worsen retinopathies such as diabetic retinopathy and leukemic retinopathy. Though itself it may not cause retinopathy. The level of hemoglobin concentration at which retinopathy can occur is not known, but it is known that most patients with a hematocrit with a hemoglobin less than 5 will have some retinopathy, and those with hemoglobin over 6 will not have retinopathy. And 1/3 of those between 5 and 6 will have retinopathy. Now, why does retinopathy happen in anemia? Is because of retinal hypoxia, leading to increase in the transmural, which leads to dilatation of the retinal vessels. This leads to increased transmural pressure. This pressure and the hypoxia damage the vessel wall, leading to vessel wall leakage, hemorrhages, exudates, edema, and cotton wool spots are caused by the hypoxia. Thrombocytopenia contributes by retarding healing. Now, in addition to the mentioned hemorrhages, which can be superficial and flame-shaped, or they may be deep and dot and blot, these hemorrhages may have a white center. They may be pre-retinal or vitreous hemorrhages. Macular star may be there, but more specifically, pale retinal arterioles, dilated and tortuous veins may be seen, and fluorescent angiography may show an increased retinal transit time. So it is generally not possible to determine the type of anemia from the retinal findings. And unlike hypertensive retinopathy, anemic retinopathy is seen more commonly in adults and not in children, unless it is caused by leukemia, where it may be also seen in children. Now, this is an anemic patient with a pale disc, tortuous blood vessels, white-centered retinal hemorrhages. Another patient with extensive intraretinal hemorrhages, retinal edema, and serous retinal detachment. This is a patient with megaloblastic anemia, white-centered hemorrhages. Anemia is more common. Anemia associated with malaria has a high incidence of retinopathy. Aplastic anemia has been reported as presenting with peripheral non-perfusion neovascularization. Iron deficiency anemia has been reported with retinal arterial occlusions. Angioid streaks may also be caused in certain familial anemias. And proliferative retinopathy resulting from non-perfusion has also been described. Now we come to leukemic retinopathy, which is seen in up to 50% of the patients with leukemia, and it is more common in adults than in children, in myeloid leukemia versus lymphoid, and in acute rather than chronic. So if you see below the line below, it shows it is most common in acute myeloid leukemia, then comes acute lymphoid leukemia, then chronic lymphoid, and last chronic myeloid leukemia will have retinopathy. Here again, it's the red blood cell count and platelet count which correlate most strongly, and it is not correlated well with the white cell counts. Leukemic retinopathy is very much like anemic retinopathy, hemorrhages, white-centered hemorrhages. These white centers contain leukemic cells, platelet fibrin aggregates, and septic emboli. But what is specific to leukemic retinopathy may be the abnormal color of the vessels, sheathing of the vessels, leukemic infiltrates, white clumps or masses in the vitreous, retina, subretinal space, choroid, optic nerve, and along the retinal vessels, and leukemic hypopyon. These are specific to leukemia as versus anemia alone. So these are patients with massive pre-retinal hemorrhages, subhyaloid hemorrhage bilateral. Usually these are bilateral. This is another patient with bilateral hemorrhage. But when we saw his periphery, there was also CMV retinitis because of immunosuppression caused by chemotherapy as well as caused by leukemia, and resolved on treatment very rapidly. Subretinal leukemic infiltrates seen in the left, and along the vessels, leukemic infiltrates on the right side, perivascular. This was a young girl with AML And fluorescent angiography shows the pinpoint hyperfluorescence, multiple punctate lesions giving a starry sky appearance seen in VKH. Proliferative retinopathy can happen from non-perfusion, but this is more often in the periphery, unlike diabetic retinopathy, which causes proliferative retinopathy at the posterior pole. Central retinal vein occlusion can be seen due to the hyperviscosity and hypercoagulability, exudative retinal detachments as a result of choroidal infiltration, and choroidal deposits can give rise to a leopard skin or a giraffe appearance. So this is a leopard skin appearance because of choroidal deposits, and they do not respond to steroids or anti-inflammatory. They need chemotherapy because this is actual deposition of leukemic cells in the choroid. It can cause RP, pigmentary changes, bilateral CSR, and miliary nodules of the retina. Polycythemia is a type of blood dyscrasia where there is a erythroid hyperplasia. Only the RBCs are overproduced. And that leads to hyperviscosity and thrombotic complications. So typically dark, dilated, tortuous retinal vessels are seen. But also because of hyperviscosity, retinal vein occlusions, retinal artery occlusions with neovascularization have been described. This is the bilateral retinal vascular dilatation and tortuosity. Treatment of retinopathy with blood dyscrasias is treatment of the underlying disease, which reverses the retinopathy. But when there is a vein occlusion and neovascularization, that has to be treated with laser and or anti-VEGF therapy. So thank you very much for your patient hearing. I think I've gone very fast.
Thank you, ma'am. I think that was a really comprehensive lecture and covering all the topics and to the point, as should be for the residents, and is going to be helpful for all the residents. So, ma'am, we have Anita ma'am. Anita ma'am is also our ANB coordinator, and she is currently working in Gangaram Hospital. Ma'am, any comments from your side before we proceed to the questions?
Good evening, ma'am. Thank you for such a wonderful talk. Yes, Pranita, ma'am has covered it so nicely. Like for resident, the topic is nicely covered, so nothing left from to discuss more. But yes, we can take the questions, whatever the residents have asked, so that will further add to the discussion. Thank you, ma'am, for the wonderful talk.
I don't know how, I mean, I was trying that I should not overshoot. So I think it became a bit short.
Yeah. Ma'am, one of the resident has asked, ma'am, which grading system should we follow for the hypertensive retinopathy while grading in the OPDs?
There are several, but as I showed the most common, that Keith Wagner, that seems to be the most popular, most commonly used, and it is also the most practical. So that is for acute hypertension. And then there is a sclerotic component. So when we see a patient, we should first try to see whether we are seeing changes of acute hypertension only, or we are seeing sclerotic changes as well in terms of increased light reflex, copper wiring, silver wiring. Because if we are seeing sclerotic changes, then we can say that the patient has chronic hypertension, 10 years plus. Patient may not have known. They may say, no, I only developed it 1 month back. But if we are seeing sclerotic changes, it's a 10-year plus hypertension. So this is one thing. And then if it is acute hypertension, we should apply that which I showed just now. The grade 1 being generalized arteriolar attenuation. Grade 2 is focal attenuation with AV nicking. 3 is presence of hemorrhages, hard exudates, cotton wool spots. And 4 is disc edema. And sclerotic, now if we start seeing sclerotic changes, then that also we have to grade. So we should write hypertensive grade retinopathy grade 2, sclerotic changes grade 3, something like this. We can write like this to both the things. So sclerotic is again, there's only one type of sclerotic classification in which there is one is increased arteriolar light reflex, 2 is AV crossing changes, 3 is copper wiring, 4 is silver wiring.
Okay, ma'am. So, ma'am, another resident has asked, what is the importance of the Wong-Michel grading system and should we use it routinely?
Von Michel, I don't know what that is. I mean, can they elaborate on it?
Okay. Ma'am, I think this was a very favorite question that Atul sir used to ask us as residents in rounds. So it has a systemic comorbidity associated with it, in which mild, moderate, and severe, they also tell
Oh,
us the systemic risk of MI and stroke for the patient. So,
got it. So
yes,
mild, yeah. I did not know the name.
yeah,
Mild is grade 1. 2 and 3 come, I think, in moderate,
yes,
and 4 is severe. So
yes.
what is the systemic risks? Can you tell me? Yes.
Ma'am, I don't know and remember, but they probably graded into this risk of MI and stroke from mild, moderate, and severe. It was in increasing ratio. So I don't remember that in very much in detail. Okay.
Yeah,
Now,
you're
Anita,
right. I removed that slide actually because of the time. But yes, mild, moderate, severe. Mild is grade 1. 2 and 3 come into moderate, and
moderate.
severe comes into this grade 4. That's true, but I'm not sure that they are related in a very exact
Yeah.
percentage wise.
Yes.
We know that as the severity increases, the systemic risk increases.
I think it's just in the exam that a lot of names and named classifications are just asked more of theory purpose. And
Yes, that is more of theory purpose only because clinically we never use that. That's why I think ma'am has not added also.
yes.
And
So
it's
yes,
And
because
I
of the
remember
but they
in
should know
my
the name.
yeah.
Yes. Mm.
Even in my final MD exam, I had a long case, and that was a case of bilateral papilledema. So what happens is by the back end, from the back end, you obviously get the information what the case is about. And so even I knew it's a case of bilateral papilledema, and I'm working according to neuro-ophthalmic case. Suddenly I dilate the patient and I see all the hypertensive retinopathy, choroidopathy changes of Elschnick spots and the cigarette streaks, as ma'am showed in the images, which we routinely have never seen in our postgraduate days. And suddenly the patient turned from a bilateral papilledema to a grade 4 hypertensive retinopathy to choroidopathy. So it's not that such cases cannot come in exams. I had that in my long case in MD exam itself.
true.
Ma'am, any questions from your end, Anita ma'am?
No, not many. Any no more resident question?
No, I'm just checking on that. Any other thing that you want to ask, ma'am?
Ma'am, what are the important points we can tell residents and how they can differentiate between the papilledema, bilateral papilledema, and the hypertensive retinopathy grade 4? So, what are the important points that they can mention?
See, papilledema by definition is only when there is raised intracranial tension. Now, most of the time it is either idiopathic raised intracranial pressure, which is called BIH also, or IIH, or it could be a tumor in the brain, or it could be hemorrhage. In that case, we will only see isolated disc edema, but we will not see retinal hemorrhages, cotton wool spots, macular star. All these things will not be there. Patient's blood pressure can be checked immediately, so that will not be high. So the accompanying other signs of retinopathy will not be there, only isolated disc edema, which over long time can start causing some changes around, even some hard exudates can come in. Chronic papilledemas, hard exudates may come, but by and large, there will be no associated retinal changes. Plus, there will be other symptoms of headache, raised ICT, vomiting. The picture of the patient will be different. Uh, so these are the ways you can make out.
Yes. So basically, first most important point is checking the blood pressure also. So to differentiate. Yes, ma'am. Thank you.
Another resident has asked, ma'am, pre-eclampsia and eclampsia patients are always sent from gynae ward for screening of hypertensive retinopathy. Ma'am, what is the relevance?
It's very relevant because if you start seeing significant changes, just sclerotic is fine. But if you start seeing exudative retinal detachment or cotton wool spots and all, then that is more of an emergency for them to manage the hypertension or terminate the pregnancy, because that also signifies danger to the fetus, to the child, as well as mother, both. So when there is severe, it denotes target organ damage. Retinopathy in eclampsia is denoting target organ damage. So what they cannot see themselves is what you can guide them with the retinopathy, which allows them to immediately either accelerate the treatment, escalate the treatment for hypertension, and if it's not coming down, to deliver, have a cesarean or.
Yes. Residents often do not understand that and they keep ignoring the consultations from the gynae ward, and then it becomes a problem. So that is the most important thing that ma'am has highlighted. It's
Not
about
only that,
target.
there is a visual prognosis also can be if there are exudative retinal detachments and we have not guided the gynecologist, then later on the patient also loses vision from chronic exudative RDs, hemorrhagic RDs. Patient can go blind from ischemic optic neuropathy, severe AION. So then ultimately we are liable for that also.
Yes.
As a team.
Yes, definitely, ma'am.
Ma'am, how commonly we see the anemic retinopathy? Like you have very nicely explained about the features.
How common? As I mentioned, just anemia does not seem to cause it. There is an associated thrombocytopenia needs to be there. So usually it is seen as part of leukemia when there is associated thrombocytopenia, or there is some sepsis where there is associated thrombocytopenia. So these are the various malignancies also. It could be myelomas. So in general, we don't, just with anemia, it's very uncommonly seen. If you see just with anemia, then it has to be very profound anemia. The anemia, the levels hemoglobin levels may be 2.5, 3 or 4. Otherwise, by and large, just anemic retinopathy does not happen unless it is with thrombocytopenia. We see it very commonly in patients with leukemia. Very common. There it's very common as hemorrhages, particularly as premacular hemorrhages, subhyaloid hemorrhages, very common.
So maybe if clinicians are seeing these such type of retinopathies, and if there is no already positive history of diabetes and hypertension, maybe we can go for the complete blood count along with the workup.
Yes, of course, yes. Whenever we see such any hemorrhages, even in diabetic hypertensive, though that picture is different. This picture is different. There you see more of microaneurysms. Here you see larger hemorrhages, which are with white centers, flame-shaped hemorrhages. So picture is different. So especially in a non-hypertensive, yes, immediately we do a blood count, even peripheral blood smear. Immediately there should be a complete hemogram, yes. Also coagulation profile.
Yes, along with CPC. Yes.
Dr. Ankur is also here. Dr. Ankur, any questions from your end to ma'am or from the residents that you can see?
Good evening, ma'am. Wonderful lecture, ma'am. I just have two questions which have come across to me by my residents. One is that
Can't hear you.
You've got muted, Dr. Ankur.
sorry, ma'am. Sorry for the interruption. Can a patient of hypertensive retinopathy present with vitreous hemorrhage?
Hypertensive retinopathy yeah, why not? These pre-retinal hemorrhages will burst into the gel. Subhyaloid bursts into the gel and causes intra-gel hemorrhage, which is vitreous hemorrhage. Yes, why not?
And then the second question is that how do we, well, these are the questions which have come from the resident. How do we differentiate grade 4 hypertensive retinopathy from a patient of CRVO?
Grade 4 hypertensive retinopathy from CRVO. Very good, very good question. But grade 4 hypertensive retinopathy will have many, first of all, it will be bilateral. CRVO will be mostly unilateral. CRVO is not such an angry picture. Grade 4 hypertensive retinopathy is all fire. Lot of hemorrhages, lot of white-centered hemorrhages, which you don't see in CRVO. Pre-retinal hemorrhages, subhyaloid hemorrhages, and the disc edema of grade 4 hypertensive retinopathy is much more than any kind of edema in CRVO. That is a mild nominal disc edema. So I think unilaterality, less disc edema, less hemorrhages, less fiery picture, and more of macular edema. CRVO will present with immediate cystoid macular edema, whereas a hypertensive grade 4 may not have any retinal edema or cystoid macular edema. Instead, that will be more of hemorrhage. It could have serous detachment. The hypertensive retinopathy more commonly has serous macular detachment, whereas CRVO has cystoid macular edema.
Thank you, ma'am. Absolutely. Uh, Sometimes patient comes with, as you said, serious detachment of the fovea, which is secondary to the detachment of the fluid coming from the disc because of the hypertensive retinopathy. In the CRVO patient, as you have rightly said, you will have a CME, cystoid spaces in the intraretinal cystic spaces. So that is one great way to differentiate the two. And rest, as you have mentioned. Thank you, ma'am. Thank you for the wonderful answers.
The serous detachment is actually believed to be because the choroid is ischemic, and that leads to RPE damage. And the RPE stops pumping out the fluid from the subretinal space, which is its function. And that is how exudative RD or even serous detachment of macula happens. So it's basically choroidal ischemia causing serous detachment.
Thank you, ma'am.
Thank you. Thank you so much, Ankur. When they coexist, when diabetic and hypertensive retinopathy coexist, they are known as mixed retinopathy.
Yes.
We often get referrals from nephrologists because they are trying to understand whether the renal disease is from hypertension or from diabetes. So is it a diabetic retinopathy? Is it a hypertensive retinopathy? What is the grade of hypertensive retinopathy, which helps them to understand the renal disease better. And many times they are able to avoid biopsy. If we can tell them that there is significant diabetic retinopathy, then they don't need to do a biopsy. They know that the kidney disease is diabetic. So I think most of our referrals come from nephrologists and then oncologists for the leukemia. Very often leukemic patients present with sudden vision loss from unilateral or bilateral premacular hemorrhages. So very often they will complain of sudden vision loss and then you find these hemorrhages. Most of these hemorrhages will clear without any sequelae. As long as they are pre-retinal, they will not leave behind any vision loss. The vision loss will happen if these are subretinal hemorrhages, which can happen sometimes. Or if these are intraretinal at the fovea, that will leave behind some damage because it will damage the retinal layers. If it is subretinal, it damages the photoreceptors. But if it is pre-retinal, then it clears without any sequelae. So we need to examine the patient carefully before we tell them that you will get back your vision or you may not get back your vision. If the patient, a leukemic patient can, or even an anemic patient can develop CRVO because of anemia and leukemia. So there now it's a combined thing. It's CRVO as well as a leukemic retinopathy. So again, prognosis gets guarded. In a leukemic retinopathy, prognosis may be good. But once they develop CRVO, now the prognosis depends on whether it's ischemic CRVO or not, whether they will keep developing cystoid macular edema or not. So examination in these patients needs to be very careful. They could have neovascularization if it is slightly chronic from non-perfusion. So then that needs laser. So examination needs to be very careful before we prognosticate these cases. And most of the time we cannot operate these patients because they have very low counts. They are not fit for surgery. So anyway, we have to wait and watch till we can actually operate on these vitreous hemorrhages. And I've never had to operate. Most of them clear anyway. Over months, they just clear.
Thank you. I think, Pranita, do we have any more questions from the audience?
No, sir, we are done with the questions.
So the classification system that you were discussing, that is actually used by medicine specialists, not ophthalmologists.
Yes.
Because I used to be part of those exams where Dr. Ratul used to be there. So most of the time, ophthalmologists they don't use this classification.
Yes.
That is one, and few of the common viva questions that is being asked just for the students is how to classification for acute hypertension and what is the classification system used for chronic hypertension. That is a very common question. And what are the choroidal changes, as you highlighted? That is a very common question. And as Dr. Ankur asked, causes of vitreous hemorrhage in hypertension patient or hypertensive retinopathy. That's a very common question among the examiners. But most of the time, hypertensive retinopathy is a theory question. So I think ma'am has covered all the point that is very essential because this often comes as a short note, not a long essay type of question, but it comes as a short note. And that ma'am has perfectly covered all the topics for residents. That is what is needed. Don't invest so much time because there are other important topics also that you have to cover. So this is good enough. Whatever ma'am has discussed today, that much is sufficient for PGs. And with this, I think you have already displayed the certificate, ma'am. This is a short appreciation. This is a small appreciation from our side, and we are doing our annual DOS on 13, 14, 15 June at Bharat Mandapam. And I request you to please join us And there, if you can join us, then we'll give you a frame certificate of this this certificate. Now we'll email you this certificate. And thank you again, ma'am, for joining us. And we'll keep on bothering you in our future resident-oriented programs.
That
And
was-
Pranita, I think you can conclude now.
Yes, thank you. Thank you, ma'am, for your valuable time and for all the efforts to make that presentation for the residents. And thank you, Praful sir, Anita ma'am, Ankur sir, Dr. Ankur for being with us for this class. Good night, everyone. Thank you.
Thank you. Thank you, everyone. Thanks to DOS and all the panelists here. Thank you very much.
Good night, ma'am.
Good night. Good night.